everyone, this is Suprava. Welcome back to another session with me. In today's session, we will be discussing about neural tube defects. So, neural tube defects is basically, a congenital malformation of the central nervous system. And if we see the prevalence, it is the most common birth defect in India. So, what is neural tube? So, basically, neural tube, forms the embryonic brain and the spinal cord and also the central nervous system. So definitely, if there is, neural tube defect, then, the central nervous system is going to get affected, right? So there would be, defects in the skull, the vertebral column, the spinal cord, and the other portion of the CNS. So there are several neural tube defects that we would learn in the later slides. But as I told you that, this neural tube forms the embryonic brain, the spinal cord, and the, central nervous system. So this develops very early in the embryonic development, right? So when the embryonic development is happening, the neural tube, starts to form the very early stage. So even before the mother knows that she's pregnant. So this is about the development of neural tube and the function of it, right? What it does. But the defect also, even the disorders of the neural tube, if we see those, that also happens, very early. So during this embryonic development, the neural tube defect also happens very early when when even the mother is unaware about the pregnancy. So it is that early. So what we understood basically is that neural tube defects are the congenital malformation of the central nervous system. That means it will be present at birth. It is a birth defect, and it results from a defective closure of the neural tube during early embryogenesis. Now, how early it is? It is between 3rd and 4th week of intrauterine life. So you can understand that, how early does it happen, even the defects. Now, the next question is, why does it happen, right? So what are the causes of neural tube defect? Now, the exact cause of the neural tube defect is unknown, but there are several other factors which are considered to be the cause or risk factors, we can say. So the first one is genetic factors. Now, genetic factors plays a major role in a neural tube defect. And then other than that, there is also nutritional factors. So if the mother is obese, for example, there is again the chance of getting, neural tube defect is higher. So, multiple environmental factors, and it is basically caused by, combination of several of these factors. And then the next one is if there is poor intake of folic acid during pregnancy. So it is recommended that even if you're not planning to become pregnant, in that case also you should consume 400 mcg of folic acid each day. And then if somebody is planning to, conceive, in that case, they should, before, like 1 month before, they should start consuming 4000 mcg of folic acid. And during the first 3 months of pregnancy, they should consume at least 4000 mcg of folic acid. So this is the recommended dose. Now, if there is poor intake of folic acid, in that case also, it plays a major role in neural tube defect. And then if there is intake of, anti-epileptic medications during the pregnancy. So if the mother is consuming anti-seizure medications or anti-epileptic medications during the pregnancy, in that case also, the risk would be higher. Well, next let us move on to the pathophysiology to understand how does it forms the neural tube and even the defects, right? So the neural plate appears on the 17th day of gestation as a thickening of the embryonic ectoderm. So you can understand how early it is, in the intrauterine life, that is 17th day of gestation, right? So on that day, the neural plate appears. And then on day 18, the neural plate folds along the midline. So by the end of the 3rd gestational week, the neural folds fuse to form the neural tube. So you can understand that by the end of the 3rd gestational week, the neural tube will be completely formed, right? So even if there is any neural tube defects, that would also, happen even, this early. So by the end of the 3rd gestational week, the neural tube would be formed. Now the anterior and the posterior ends, that's called as neuropores, these two would closest to form the spinal cord. Now depending on the point of interruption in the neural tube formation, different types of neural tube defects may occur, and based on the type it would be, it would determine that it might affect the brain, that is called as anencephaly, and it might also affect the spinal cord, so that is called as spina bifida. So next, moving on to the types of neural tube defects. So the first one is spina bifida. Now this is the most common anomalies of neural tube development seen in infants. So we can say that among all the types of neural tube defects, spina bifida is the most common one. Well, here two things we already know. So the first one is that it has affected the spinal column, because we already, we have already seen that if it affects the brain, we call it as anencephaly, and if it affects the spinal cord, we call it as spina bifida, right? So here it has affected the spinal column definitely, and the second one is that there is, it has happened due to failure of the fusion. Now, which part has failed to fuse together, that we need to see here. So basically here, the posterior portion of the lamina of the vertebra fails to close. So there is failure of, the fusion of vertebral arches. Now it might be with or without protrusion of the meninges, and there might be dysplasia of the spinal cord. Now there might be only a small deformed lamina, or also there might be a complete absence of lamina. So we can broadly divide spina bifida into two groups. That is, first one is spina bifida occulta, and the second one is spina bifida cystica. And then spina bifida cystica also can be classified into two major groups. So it is commonly found as meningocele and meningomyelocele. So first we would learn about spina bifida occulta. Now spina bifida occulta is the most frequent one, and it is the most benign neural tube defect. So there is defective closure of the posterior arch and the lamina of the vertebrae, which is usually L5 and S1. So here there is a prominent feature that you can see in spina bifida occulta, that there would be dysplasia of the spinal cord. And apart from this, we can here there would be no protrusion of the meninges, and most of the cases are asymptomatic. Now some children might present with cutaneous lesions over the defect, as tuft of hairs, or there might be lipoma or hemangioma, or sometimes is a dimple in the skin. The symptomatic children usually present after 6 to 8 years of age. So we can see that there would be progressive deformity of the foot. Also there would be changes in micturition pattern, and there would be alteration in the gait, and tropic ulcers on the toes and feet. And if there is progressive neurological deficits, in that case it requires surgical intervention. So in that, basically laminectomy is done, and in some cases, even before the neurological deficits appear, they can perform the surgical correction. So in that case, myelo-CT and MRI, these would help us to confirm the diagnosis even before the surgery. And then next we have spina bifida cystica, which we already know that it can be classified into two major groups. That is, the first one is meningocele and the second one is meningomyelocele, right? So first we would see meningocele. So meningocele actually is, it is a hernial protrusion of the meninges. So there would be protrusion of the meninges through a midline defect in the posterior vertebral arch. And this would form a fluctuating cystic swelling, which would be filled with CSF, and it would be covered by a thin transparent membrane or with the skin. And generally it can be found in the lumbosacral region, which is at the lower back, and also this may be found in the thoracic region and in the skull, which is called as cranial meningocele. And here there would be no dysplasia of the spinal cord, and it is also asymptomatic. So this is not that common. It is a kind of rare lesion, And even if there is symptoms, the symptomatic child may present with weakness of the leg, or lack of sphincter control might be present. So here there is a risk that, as the sac is there, it might get infected. So to prevent infection, surgical closure is needed as soon as possible. And the next one is meningomyelocele, or it is also called as myelomeningocele. Now, this is a midline cystic sac of meninges which herniates through a defect in the posterior vertebral arch. Now, this is one of the most common lesions, we can say, and it can be present anywhere on the midline in the back, but the most common site, if we see, that is lumbosacral region. It is same like the previous one which we saw, that is meningocele. So there also we learned that the most common site would be, the lumbosacral region. Here also it is same, though it can be present anywhere in the midline, but the most common site is lumbosacral region. But here there is a difference. So we learned in meningocele that there would be no dysplasia of spinal cord, right? But here we can see dysplasia of the spinal cord, and this is always accompanied by a neurological deficit. Well, the child with myelomeningocele may present with flaccid paralysis. There might be absence of sensation and drop reflex. And there might be several other, postural abnormalities. For example, there might be club foot or subluxation of hips may be present. And in older children, we can see there would be contracture of joints. There might be scoliosis, and kyphosis also might develop. Also, if the sac is not corrected surgically, there is a chance of infection of, or risk of infection of the central nervous system. And also there might be rupture of the sac. Next, we would see that, if it affects the brain, then what are the different types of neural tube defects. So the first one is anencephaly. Now, this is a congenital absence of the cranial vault. So here in anencephaly, you can see, in the picture that there is absence of the cranial vault, and also with the cerebral hemisphere. Now, the cerebral hemisphere might be completely missing, or, it might be reduced to a small mass. And generally, anencephaly is, is associated with other congenital anomalies. For example, there might be congenital heart disease, there might be cleft lip, cleft palate, etc. But this condition is incompatible with life. So usually death would occur within 1 or 2 weeks after birth. Next, it is encephalocele. So encephalocele is it is a sac-like protrusion of the meninges. So there would be protrusion of the meninges with brain substances. That means there might be cerebral cortex or cerebellum or part of the brain stem. So there would be herniation of these structures through a congenital bony defect in the skull. And it is commonly found in the midline and in the occipital and parietal area, but it can be also found in the frontal bone and in the orbit or in the nose. So if the child survives, in that case also later in life, the child might have hydrocephalus, or there might be visual problems, seizures, or microcephaly, and it can also lead to mental retardation. And in this also there might be associated congenital anomalies. For example, there might be cleft lip, cleft palate, or abnormal genitalia or congenital nephrosis, etc. So I hope you have got a better insight about the topic. Thank you.